There's a lot of conflicting information out there, so I'm hoping to add some clarity today to all of that. And in order to do so, we have to start in the beginning. So, the first hormone therapy, they actually used to get estrogen from the urine of pregnant women, which was quite expensive and labor intensive. So, by the 1940s, they switched over to horses, and that's where we got that conjugated equine estrogen, and it's in the brand name Premarin, pregnant mare urine. And there was a huge uptake in the use of hormone therapy, so that by the 1960s, it was thought of as pretty much the fountain of youth, and everyone should be on it. Dr. Robert Wilson was a huge proponent of estrogen and used to infamously tell women, if you want to keep your looks in your husband, you better go on estrogen. By the 1980s and 90s, we started looking more closely at hormone therapy for more prevention. So in the 1980s, they introduced progestin to protect the uterus so there wouldn't be an increased risk of uterine cancer. Osteoporosis started getting more attention when they learned that estrogen could prevent it from happening. So then they started asking, could hormone therapy prevent chronic disease, including heart disease in women? We knew women's risk of heart disease goes up during menopause, so there must be some type of benefit with estrogen, right? And so that was that infamous WHI, the Women's Health Initiative, that got published in 2002. And what they found out was giving hormone therapy to older women was perhaps not the best idea. When they re-looked at the data for younger women, so women between the ages of 50 to 59, that data actually looked very promising, but that was not what was splashed all over the media. So there was this huge fallout. There was an 84% drop off of prescription therapy for menopause. Now, of course, that doesn't mean menopausal women didn't exist anymore. And so that's where a compounded bioidentical hormone therapy really started to increase in number and size. And what they were saying is, look, we're using different hormones. We're using estradiol and micronized progesterone, which is different than the WHI, and we're safer. And they actually coined the term bioidentical, which did start as a made up medical term or made up marketing term. Now, there's always different ways to practice menopause. I follow the Menopause Society, and they've more recently updated their guidelines. So we're no longer telling women you have to be on the smallest dose for the shortest amount of time. You have to stop at 65. Now that dose and duration is individualized, which is probably how this should have been from the very beginning. Now, has the pendulum swung too far? I've been specializing in menopause for over 10 years, and the evolution of our perception of hormones is fascinating to me because now I have women coming in saying, I watched the Oprah show, I heard something on TikTok, and everyone's supposed to be on hormone therapy. It's great for everyone, it protects the heart, right? And that's not entirely accurate. So that's what we're going to talk about today. First things first, a very basic definition of menopause is a person is no longer ovulating. And this can happen in one of two ways. The first way is what we would call a natural menopause, so the person outlives their ovaries, or you can have what's called an induced menopause. And these are when the ovaries are surgically removed or they're damaged, such as with chemotherapy or radiation, and that's the reason why that person's no longer ovulating. When this happens, women lose about 90% of their estrogen. And if they didn't know, they quickly find out that they have receptors for estrogen everywhere. So everything gets impacted. So, to name a few, you have your change in the menstrual pattern, which is a very early sign. You can have vasomotor symptoms, which is the medical term for hot flashes and night sweats. You can start to have mood changes, trouble sleeping, which usually means staying asleep, weight gain, especially right in the abdomen, overall achy muscles and joints, headaches, more thinning of your hair on your head, but more what we call hirsutism, which is when women start to have some facial hair. It's usually kind of along that jawline or at the chin. Acne can start to happen, and then fair to say everything gets dry. Skin, hair, fingernails, vulvas, vaginas. And there's also a lot of bladder symptoms, so more urgency, frequency, even more bladder infections. So I love hormone therapy because ideally it can address everything that we just mentioned because the root cause of that is that 90% drop off of estrogen. But these are the official FDA approved indications. So moderate to severe vasomotor symptoms to prevent osteoporosis, or if someone goes into menopause before the age of 40, there should be a really strong contraindication to not put that person on hormone therapy. And as much as I love hormone therapy, there are contraindications, and that includes this unknown cause of vaginal bleeding, which your provider should be able to figure out pretty quickly. Liver disease, if you yourself have had a blood clot in your chest, your arm, or your leg, you have a history of an estrogen dependent cancer, you have some significant heart disease, you've had a heart attack, you've had a stroke, or there's an inherited high risk of a clotting disorder. Now, sometimes people make the mistake of assuming that all these hormones are the same and they call everything estrogen and progesterone, but that's not entirely accurate. So, looking at that left hand side, the estrogen is what we use to help people with all of those bothersome symptoms, but that's just an umbrella term. So, below that is all the different kinds of estrogen. So, we have estradiol, which, if instead of calling it bioidentical, since that started as a marketing term, we really should consider calling it isomolecular. And that means it's chemically similar to what the ovaries produce. And you don't have to have this compounded. You can have this made, or excuse me, you can pick this up at any pharmacy. Your insurance will cover the cost. Then we've got that conjugated equine estrogen, which is that Premarin that we talked about. There's estetrol, which is not yet available for menopausal hormone therapy. It's in one type of birth control right now, and I'm still anxiously awaiting to see the data on this estrogen because it does look like it might have a really nice safety profile. And then we have ethinyl estradiol, and that's what we usually use in contraception. Then on the right-hand side, if someone still has a uterus, we have to protect it. And although everyone calls these things progesterone, a better umbrella term would be progestogens, because below that, that micronized progesterone, that's the only true progesterone. And again, that's isomolecular or chemically similar to what the ovaries produce. And then everything else are progestins, and we use those to help with heavy or frequent uterine bleeding or in contraception. So again, we know estrogen must be beneficial to the heart because we know women's risk of heart disease starts to go up once they go into menopause. And these are all the things that estrogen can potentially help with. So it's an antioxidant. It helps with vasodilation by binding to those alpha receptors. It helps with the release of nitric oxide, prostacyclin, can help inhibit that vasoconstriction, and it might even contribute to some of these anti-inflammatory processes in the arteries. But again, we can't just assume that that's true of all estrogens. So estradiol is actually more beneficial. That binds more with the alpha receptors, which ends up being helping more with that vasodilation or the relaxing of those blood vessels. Whereas conjugated equine estrogen binds more with beta receptors and it's not as beneficial to the heart. And then ethinyl estradiol does not improve nitric oxide or help with the vasodilation, which is why we've never had the debate of giving women contraception to help prevent that infamous WHI study. So this one can actually increase insulin resistance and actually increase blood clots too. So it sounds so promising. So why aren't we giving hormone therapy to prevent heart disease? So there's what they call this estrogen and the timing hypothesis. So when a person goes into menopause and they lose all that estrogen, there starts to be a lot of changes. So more plaque, higher blood pressure, those kinds of things. And you can't put estrogen back into the body and reverse what's already happened. Hormone therapy just maintains the vascular health. It doesn't treat it. And we know if we wait more than 10 years from someone's last period, or if we don't know when they had their last period, say they had a hysterectomy, and they're older than 60 when we begin it, then we actually increase the risk of heart disease, which is what they discovered in that WHI study. So our North Star to kind of guide us on who's a really safe candidate for hormone therapy are women within 10 years of their final period, or if they're younger than 60 years old. However, your vascular age is going to be more important than your chronological age. So you could be 52 years old, but if you've had some pretty significant heart disease or, say, a lot of increased lipids and whatnot, then this still might not be a safe option for you because what happens sometimes with estrogen is once we introduce it, if there is, say, significant plaque buildup within the arteries, this can cause that to dislodge. So the safest options for the heart and blood vessels would be the estradiol. So that's the one, it doesn't worsen blood pressure. And if we give it transdermally, it doesn't risk, you don't have an increased risk of a blood clot. So transdermal means anything that just gets absorbed right into the skin. And that could be a patch, a spray, we have gels, and even a vaginal ring. And the reason why that doesn't increase the risk of a blood clot is because normally when you swallow estrogen, it goes through the liver, and that's what activates those clotting factors. So we're essentially just taking the liver out of the equation so that you don't have that increased risk of a blood clot. And then if you still have a uterus and we need to protect it, then that micronized progesterone doesn't impact blood pressure, and there's less risk of a blood clot with that compared to the progestins. Now, there's lots of non-hormonal options, of course. So these are options for people who either don't want to go on hormones or perhaps they're not the safest candidates for it. And this was a really nice position statement that came out 2 years ago. So now they call themselves the Menopause Society, but before that, they used to go by the North American Menopause Society. And this has a summary of all of the non-hormonal options, what the data says, what the research says. And this is helpful when someone comes into the office for me and they have a bag of supplements and vitamins and say, what should I take? Is this safe or not? So this is a nice place to look that up. But I'm going to go over some of the prescription options for you. So the first one that was FDA approved is called Brisdal. It's a really low dose of this paroxetine salt. At a higher dose, the paroxetine or the brand name Paxil is used for mood disorders, but at this low dose, this is just for those vasomotor symptoms, and a lot of my patients feel like it helps them sleep too. At this really low dose, you're not going to have the usual side effects of weight gain or sexual dysfunction, but it's also not going to treat moods. The other prescription option is Veoza. This came out about over a year or so ago. You might have seen some of the commercials for it. This is a neurokinin 3 receptor antagonist for the treatment of moderate to severe vasomotor symptoms. So what does that even mean? So what they think is happening with the hot flashes and night sweats is that there's this internal thermostat within the brain and within the hypothalamus, and these nerves that project into it are normally in a really nice balance. So you've got estrogen, kind of think of that as the brake pedal, and then you've got your neurokinin B or that NKB as the gas pedal. So then in estrogen, when all of the estrogen goes away in menopause, now you just have this nonstop firing into that internal thermostat. So Veoza can come in and block some of that firing and can then help with hot flashes and night sweats. Now, we also have what we call off-label use. So what this means is that the FDA has not officially approved these products for hot flashes and night sweats, but we have data to support that it's safe and effective. So this first one, these SSRIs and SNRIs, these are usually used for, say, like anxiety and depression, but they can also help with hot flashes and night sweats. This is a really nice option for someone who tells me, for example, well, I'm having a worsening of my depression now that I'm going into menopause, and I'm having all these hot flashes and night sweats, and I used to be on Lexapro, and it was really helpful. This might be a great time to restart that because then it could essentially help with both of those symptoms. Now, with any of these SSRIs, SNRIs, the potential side effects could include a decrease in sex drive, trouble reaching orgasm, weight gain, especially with that paroxetine. However, I would also caution you to remember that if you are not sleeping well and having hot flushes, night sweats, mood changes, then I'm going to assume that you will have a decrease in sex drive, trouble getting to orgasm, or weight gain. So there's a fine line here. Then we have another off-label use. This is oxybutynin. We usually use this one for overactive bladder, which is that feeling of, I have to go, oh my gosh, I have to go right now. And this works really well for hot flashes. The most likely side effect with this one is a dry mouth. We're using a really low dose just for the hot flashes and night sweats, and most of the women I work with tolerate this fine. It's considered an anticholinergic, and with any of those medications in that family, we have to be mindful of a potential increased risk of dementia. They mostly find that in older people, especially people who are on several anticholinergics. They've never done a study in younger menopausal people on a low dose for hot flashes, whether or not that increases the risk of dementia. So it's just something for us to be mindful of. And then we also have gabapentin. So gabapentin we often use for nerve pain, but it has this really nice side effect of drowsiness and can help with hot flashes. Because of that drowsiness, you could take this up to 3 times a day, but most of the women I work with cannot tolerate it during the day. They get too tired. But this really nice little low dose of 300 milligrams is great at bedtime, especially if you've got night sweats waking you up at night. And then to kind of round out this talk, I would be remiss to not talk about my favorite thing, which is the genitourinary syndrome of menopause that we shorten to GSM. And what this syndrome is all the symptoms in the vulva, vagina, urethra, and bladder from that significant drop off of estrogen, which is the itching, dryness, bladder infections, vaginitis. The prescription options are absolutely one of my favorite things. In the interest of time, I'm just bringing up vaginal estrogen and vaginal DHEA. The reason why I love these is because they get to that root of the problem and they can increase the blood flow, drop the pH, make the tissue healthier, all of those good things. Whereas in comparison, say a lubricant, it just helps with friction. These products are good when you're only having those GSM symptoms. So it really doesn't get to the rest of you. This is not going to treat vasomotor symptoms, mood changes, etc. Because you have just that really minimal amount getting to the rest of you, you don't need a progesterone. And unlike the systemic hormones, you could start this at any age. You don't have to be younger than 60 or within 10 years of your last period. You could be 102, and I'd be very happy to prescribe this for you. The Menopause Society put out a position statement on this too, which is again a nice Google search where you can see a summary of all the data. But a very brief summary is that the vaginal estrogen and vaginal DHEA doesn't increase your risk for blood clots, heart disease, hip fractures, or cancer of any kind. In fact, I would have a hard time finding someone who didn't qualify to take these products. However, they have these really scary black box warnings on them, and this warning is based off of that Women's Health Initiative with systemic hormones. So this black box warning isn't even evidence-based, which is completely maddening. And the FDA has been petitioned numerous times to have this removed because this scares women and providers and pharmacists. However, unfortunately, the FDA has declined from having it removed, but at least now all of you know the truth behind this. So, wrapping up, menopausal people within 10 years of their last period or younger than 60 are usually the safest candidates for hormone therapy. But of course, this needs to be individualized to your own risks and benefits. That low dose transdermal estradiol with the micronized progesterone is going to be the safest one for your heart and blood vessels. And remember that hormone therapy only supports healthy blood vessels, it doesn't prevent or treat heart disease. You have lots of non-hormonal options available to you, meaning no one should ever suffer with menopausal symptoms. There's always things we can do. And vaginal prescriptions is pretty much always safe for just about anyone. And my final thought that I like to say is that to remember that menopause is a privilege. I'm sure we all know someone who didn't make it to menopause. So if you did, congratulations. You're doing great and you're exactly where you're supposed to be. Thank you.